Good evening, friends. Warm welcome to you, all of you, for this Friday evening PG clinics, which has been happening for the past 4 5 years. So today we have decided to Okay. So today we have an important case presentation, Obstructive Jaundice, kindly contributed by Professor Amit Gupta from AIMS Rishikesh. And the candidate who's going to present is a MSPG resident from AIMS. So we have our invited professors for the evening, Professor Venkatrama Reddy sir.
Yes, sir.
We have Professor Vamsi sir. Both are heads of surgical gastroenterology at Narayana Medical College in Nellore. And sorry, I think there is some connectivity issue. I request the candidate to, I will do the introduction little later. So I request the candidate to start the presentation, introduce themselves, their head of the unit, head of the department, and start your presentation. Faculty, normally we allow them to present without interruption for the history part. Then we revisit all the slides from 1 to 3, and you can ask questions or give your comments. Same way, the clinical part is run through the end, and then we take back the slides and discuss all the points, whichever you feel like. And we dedicate the second half for the management and the treatment description. We warmly welcome Dr. Gayatri ma'am, head of the department, general surgery at Government Stanley Medical College. And we have our own senior faculty, Professor Nishi Gujar, Professor Ajay Khanna sir from IMS BHU Varanasi. And we have other senior faculty who have joined across the state and our nearby states. So, Dr. Sir, it is over to you. Good luck to you. Faculty, please take over. Please share your PowerPoint, ma'am.
I'm not able to share, sir, my PowerPoint.
Yeah, we are able to see the PowerPoint now.
You are enabled to share.
This is not my PowerPoint, sir.
One moment, ma'am. Are you sharing it, me?
Yes, sir.
Yes,
is it
there you
visible,
go.
sir?
Good luck.
Thank you, sir. So, good evening, everyone. Myself, Dr. Mohammad Azhar Khan, junior resident from the Department of Surgery, AIMS Rishikesh. I'll be presenting a case of obstructive jaundice. My moderator will be Dr. Amit Gupta, sir, Professor, Department of Surgery, and in charge, Department of Surgical Oncology, AIMS Rishikesh. So my patient is Miss X, age 26 years, resident of Amroha, Uttar Pradesh, and she is a student. She presented to our OPD, general surgery OPD with the chief complaints of pain in the right upper quadrant for the last 1 year, yellowish discoloration of eyes and skin for the last 30 days, passage of high colored urine for the last 30 days, and itching all over the body for the last 20 days. History of presenting illness. The patient was apparently asymptomatic 1 year back when she started having this pain in the right upper quadrant for the last 1 year. The pain was insidious in onset, dull king type, and intermittent. The pain was non-radiating. There was no aggravating factors, and the pain was relieved by oral medications. This pain was mild to moderate in severity, and she complains of increased duration and frequency of these intermittent pain episodes for the last 3 months. The patient also complains of a yellowish discoloration of eyes and skin for the last 30 days. This yellowish discoloration was noticed by herself, and the discoloration is progressively increasing. This discoloration is associated with high colored urine and pain colored stool for the last uh, 1 month, and associated with itching all over the body for the past 20 days. And there is history of appetite and unintentional weight loss over the past 6 months. She has lost 5 kilograms of weight over the past 6 months. There is no history of nausea, vomiting, abdominal distension, altered bowel habits, melena, dyspnea, or hemoptysis. There is no history of fever, chills with rigor, malaise, joint pain, or generalized weakness. There is no history of seizures, unconsciousness, or bone pain. There is no history of blood transfusion or tattooing. Past medical history. She has a history of pulmonary tuberculosis at 16 years of age, for which she took anti-tubercular therapy for 6 months. There is no history of diabetes mellitus, asthma, hypo or hypothyroidism, or hypertension. There is no history of surgery in the past, and there are no known allergies. Her menstrual history. Her menarche was at the 14 years of age. Her last menstrual period was on 14th of February 2025. She is unmarried. She is vegetarian by diet. There is no history of substance abuse, including smoking, tobacco use, or alcohol intake. She has normal bowel and bladder habits. She complains of reduced appetite, and her sleep is disturbed due to generalized itching. There is no history of malignancy or malignancy-related death in the family, and there is no history of tuberculosis in family members. So summarizing my history, lady, 26 years old, resident of Amroha, Uttar Pradesh, presented with the complaints of right upper abdomen pain for 1 year with progressive jaundice and passage of high-colored urine and pale stools for the last 30 days, with generalized itching for the last 20 days, with loss of appetite and unintentional significant weight loss uh, for 6 months with no prodromal symptoms and no known comorbidities.
Yeah. Okay.
The first slide, Dr.
Yeah, good.
Perfect.
You want to go to the first slide?
Okay, sir.
No.
Yes, sir.
Yeah. Any history you think you are missing anything in this case? Go to the next slide.
Yes, sir.
Okay. Next slide.
Yes, sir.
Okay. Next slide.
Yes, sir.
Okay. Next slide. Anything?
Yes, sir.
Okay. There's no any other history. Okay.
Awesome.
Okay. Any other history you want to mention? This is you have taken or someone has given you the history?
Sir, I have taken, sir.
You have taken. Okay.
Yes, sir.
Yeah. So any other history you are missing in this? You want to add anything?
Sir, any history of similar episodes in the past?
Yeah, that's one. And don't you think anything like something like any intermittent jaundice or its progress, anything in between? Of course, it's a short history where you may
Yes,
not
sir.
have waxing and waning,
Yes, sir.
but still,
Can you hear me?
you could have taken the history of that also, any waxing or
Hello.
waning something.
Yes, sir.
Yeah, ma'am,
Am
please,
I
ma'am.
audible?
Yeah, you can. Yeah, we can hear you, please.
Okay. I just want to confirm. Okay.
Yeah,
Yeah,
fine.
you continue. I'll join in.
Sure. Okay, that waxing and waning, if a little more longer history could have taken that, because
Yes,
that
sir.
gives you a little significant, because it can lead to many other diagnoses also, no? It will
Yes,
point
sir.
out to some diagnosis. Okay, fine. Next slide.
Yes, sir.
No, no. The first one, the chief complaints itself, from
Hmm.
the name, age. Can you go for that?
Yes, sir. Yes, ma'am.
Patient's particulars, 76 years, is it?
26
26.
year old. 26.
26. So 26 years old, do you think the cause for your jaundice is going to be benign or malignant?
Uh, Ma'am, actually, she has loss of weight and loss of appetites,
Okay.
and it is a progressive jaundice. So my first differential should be a
So, but
will be
usually 26 years old, what do you expect?
usually a benign etiology, ma'am.
Okay. 26 years old, you expect a benign one.
Yes, ma'am.
Yes.
Yes,
But
ma'am.
then as you keep going on, it changes. Your diagnosis changes. That is what you are trying to say.
Yes,
Right?
ma'am. Yes, ma'am.
Okay. I don't know about this Uttar Pradesh and all. Is it very, jaundice is very rampant there?
It is in the gangretic plane, ma'am. Jaundice, likely malignant, is more prominent. Carcinoma gallbladder is prominent, more
Okay.
prominent in
Okay.
gangretic plane. Yeah,
Okay.
ma'am.
The next slide then.
Yeah, ma'am.
Yes. Chief complaints. Chief complaints are
Pain in the right upper abdomen for the 1 year.
for
Yellowish
1 year.
discoloration. 1 year,
So
ma'am.
again, do you think this is going to be benign or malignant? 1 year.
1 year, it's a long-standing pain, ma'am. It should
Yes.
be
So
benign, ma'am. Like it's just not a
you
short,
think
it's just
again it
long.
is going to be benign, right?
Yeah, ma'am. Yes, ma'am.
Okay. So 26 years old, you thought it is going to be benign. Again, right hyper. I mean, for past 1 year, again you're thinking it is going to be benign. Even I don't know. You're thinking it's going to be benign, right?
Yes, ma'am.
Okay. Yellowish discoloration of eyes for the past 30 days.
30 days, ma'am.
Okay. Now, did you ask her? Passage of high colored urine. Which one came first? Yellowish discoloration or passage of high colored urine?
According to her, she told that yellowish discoloration came first, ma'am.
Yellowish discoloration. Which one comes first, actually? According to
Uh,
her, agreed. She told
us
you. But
yeah,
what do you
ma'am.
think will come first?
Usually, high colored urine comes first, ma'am,
Really? Why?
because patient usually not notices jaundice
Because
when
that
it
is what
is.
the patient sees.
Yes, ma'am.
The patient will not be able to see her own eyes. It is
Yes, ma'am.
usually somebody else who tells her that.
Yes,
Okay.
ma'am.
So the yellowish discoloration comes first, followed by the passage of high colored urine. But the patient is not able to see the yellowish discoloration of the eye. That is why she says both together.
Yes,
Okay.
ma'am.
She can say anything, but you should understand which one comes first and which one is noticed next. Okay.
Okay, ma'am.
Yes. Okay. So itching. Itching comes first or again later on. That is 20 days.
Yes, ma'am.
So
Usually,
that has come last, right?
yes, ma'am.
Yes, you are right. Okay. Continue.
Uh, History of presenting
Okay.
illness, ma'am.
Hmm. Yes, patient
Apparent.
was apparent asymptomatic 1 year back. Right
Yes, ma'am.
upper abdomen. I don't even know which part of the upper abdomen it is. Yes, upper abdomen is what? Above the umbilicus. Above the umbilicus is how many quadrants are there above the umbilicus? Which one is upper abdomen? I don't know. Patient can say upper abdomen, but I should know which quadrant. And
Yes, ma'am.
which
It
one is
was.
upper abdomen above the umbilicus and below the umbilicus? Is that you divided it into? That means that there are some quadrants that are divided into half, upper half and lower half. So when it comes to presenting illness, everything has to be your words. Okay, all the medical terminology that you have learned will come into play here.
Yes,
Okay,
ma'am.
so you cannot say right upper abdomen. That is what the patient said. You cannot say the same thing again. So what are you going to say?
Right upper quadrant.
Yes,
It was right upper quadrant, ma'am.
right. You also want to say right upper quadrant.
Right hypochondrium it was, ma'am.
Ah,
Right
right
hypochondrium.
hypochondrium. So
Yes, ma'am.
you are supposed to say right hypochondrium, or if it's going to be some other case, epigastrium, left hypochondrium, lumbar, and all that. Okay. So now
Yes, ma'am.
here she has said right upper abdomen, but you're supposed to say
Right hypochondrium.
right hypochondrium. Good. Carry on. Insidious onset, dull aching, intermittent. What is a dull aching pain is intermittent, is it? Which pain is usually intermittent?
Uh, Usually, ma'am, some stone
Yes,
associated pain.
dull aching pain, is it present throughout the day? Or the dull
No, ma'am.
aching pain is intermittent?
No, actually, her episodes were like it was insidious onset pain, and these episodes
Okay,
lasted
insidious
one or
onset.
two.
Okay, gradually it is increasing, right? That is what
But
insidious onset means.
yes, ma'am.
Gradually it is increasing, and then dull aching.
Yes, ma'am.
Ah, so the
But
dull
these,
aching pain, how can it be intermittent?
ma'am, actually, the patient had episodes, so each episode will last 2 to 3 days, and this pain will be relieved either on its own or by oral medications. Then she will have a episode again of this similar pain
So that
3 to 4 days
means,
after.
okay, that means it cannot be a dull aching pain. Dull aching pain usually people ignore. Dull aching pain is a continuous pain. At times it can be intermittent, but that intermittent pain will be high grade or low grade.
Intermittent usually high grade, ma'am.
Intermittent is usually
Like more pain, it will be like more
more
severe.
pain, right? You are right. So it is of high intensity.
Yes, ma'am.
Yes. So continuous pain is usually dull aching, and intermittent pain is what sort of a pain then?
It is like
What sort of a
non-specific.
pain?
It is a non-specific.
Non-specific. Colic pain is an intermittent pain or non-specific pain?
Colic pain is usually intermittent, ma'am.
Ah.
Patient,
So now we have
patient.
told me intermittent. I'm thinking it can be a colic pain. Can I take it? Can I take
It
it
was
as an echo? Yes?
it was more kind of a episodic pain, ma'am. Like these episodes happened for her
Why?
every like
What is the reason for the intermittent pain then?
it could be an intermittent obstruction, ma'am, likely
Intermittent, yes, you are right.
in
Intermittent
the
obstruction. So an obstruction causes what sort of a pain?
colic pain, ma'am.
Then that is what I'm trying to tell you. Yes. So you
Yes,
never
ma'am.
thought of that. If it's going to be intermittent, then you should rule out a colic pain because usually a colic pain is
Intermittent.
intermittent. So what sort of a colic pain? What do you think will be the cause for this colic pain?
Uh, Colic pain, if it's happening in the right upper quadrant, it
You
should
said
be
obstruction.
like
Obstruction to what?
biliary obstruction, ma'am.
Biliary
Biliary
obstruction.
obstruction.
There's already jaundice. So you think the obstruction is because of what then?
Stone, ma'am.
Okay. So you're thinking it is again a
For the
stone. Do you understand? So this is how we are supposed to analyze.
yes, ma'am.
Do you understand? So you're telling me everything for a benign disease. Okay.
Yes, ma'am.
Got it? I'm not trying to
Yes, ma'am.
confuse you, but that is what you have told so far.
Yes, ma'am.
Okay. Now pain, then non-radiating, non-aggravating. What is this? No aggravating factors.
It was not aggravated or increased post after food intake,
What?
ma'am. Not increased after food intake.
After food intake. So you are relating the colic pain to food.
Yes, ma'am.
Yes. Does the colic pain have any relation to food or not? Usually, if it's going to be something with a GIT.
Postprandial, ma'am. If it's a biliary obstruction, the pain might
Yeah.
rise, ma'am.
So you should have got more detailed history about the food and about the pain. No simply saying no aggravating or relieving factors. You
Okay.
understand? So these
Yes,
are all
ma'am.
very important history. Got it?
Yes, ma'am.
Yes. So you have missed that the pain in relation to the food should have been elicited even better than this, right?
Yes, ma'am.
This I agree, relieved by oral medications. So what exactly did the patient take? That you should get the history also. Just
Yes,
don't
ma'am.
say some oral medication, something.
Yes, ma'am.
Okay, you should ask her how many tablets she had taken, how long she had taken, all that you should know. You should
Yes,
have the
ma'am.
patience, yes, to elicit that history.
Okay, ma'am.
And suddenly this mild to moderate in severity, I don't know what it is. You said dull aching. then it became intermittent, then it became mild to moderate also. Okay. Mm. She complains of increased duration, frequency of episode. Okay, so the frequency has increased for the past 3 months.
3 months.
Means
Yes,
what
ma'am.
frequency?
The frequency of this intermittent pain, ma'am.
So the intermittent pain, the frequency, so the colicky pain has increased. Yes,
Yes, ma'am.
that means some development is still going on. Got it? This is how you're supposed to elicit the history and you're supposed to
Okay.
give us the details.
Yes, ma'am.
Yeah?
Yes, ma'am.
Okay, go to the next slide. Next slide, please. This is the one?
Yes, ma'am.
Okay. Excuse me, I'm sorry, I joined late. I don't know the names. Excuse me, sir. Hello.
Yeah, ma'am. Tell me.
Yeah, you can continue.
Yeah, one thing regarding the pain when we were talking, intermittent
Yeah.
is not always colicky pain. Of course, like we can't take intermittent means colicky. Even dull aching pain can be intermittent. That's what it means. Intermittent is only the duration, the episodes. You can have.
Now, usually
Yeah, so
intermittent pain,
that's the one.
especially in a
Yeah. So
luminal one, we take it for granted. It is colicky.
what I mean to say is intermittent doesn't mean
Some
colicky.
obstruction.
So it's like duration what we are talking about. So second thing is the pruritus need not start before your jaundice. Okay, pruritus usually comes after jaundice, especially in one
Yeah, that
case
is what we have said.
where it's a
It comes
hilar
after
cholangio.
20
You
days
can have
only.
in hilar you
20
can
days.
have
That is what he
sometimes
said.
in hilar you can have some pruritus even before the jaundice. That
Yes,
is the
but
one.
usually,
Yeah.
this is what
So
you say usually, and
yes.
then we go for exceptions.
So okay, can you go to your summary
Mm,
slide? That is,
Yes, sir.
we'll go ahead now.
mm.
Okay. Now this is the summary. So what do you think from your history and all? What do you think your probable diagnosis in this patient?
Sir, a 26-year-old presenting with pain in right upper abdomen with obstructive jaundice with loss of weight and loss of appetite. My first differential will be some secondary to malignant obstruction, sir.
Okay. What are your what are the things which are in favor of your malignancy?
Sir, favor of malignancy include first this progressive jaundice, second this loss of appetite and unintentional significant weight loss, sir.
Okay. But then what is against your malignancy?
The her age and this
Age is against
intermittent
the
pain.
malignancy. Huh?
So age is against the malignancy, but
Hmm.
uh, s- still a malignancy can happen in young age also, sir.
Okay. So, but the history is very long, no? Do you get this
History is,
long history in the malignancy? Can you get this history?
sir, we can give if it is a chronic inflammation which is turning into a malignancy.
Okay. You're thinking some chronic inflammation which is turning into malignancy and then giving jaundice.
Yes, sir.
That's what you were thinking. Okay. Okay, so if it is so if it is a benign, what do you think? It's a malignant. What your probable diagnosis?
Uh, Sir, if it's a malignant condition, either it will be uh, some hilar cholangiocarcinoma or a carcinoma gallbladder.
So how do you explain your pain for 1 year in hilar cholangiocarcinoma and then jaundice? Is it the way that presents
No,
usually?
sir. My first differential will be carcinoma gallbladder followed by this
See,
cholangiocarcinoma.
when you're going to give a diagnosis that is going to be rare,
Yes, sir.
yes,
Yes, sir.
cholangiocarcinoma, how many cases have you seen?
It's kind of
Which is
rare, ma'am.
common
Carcinoma gallbladder in North India.
in North.
Yes, ma'am.
Agreed, but
Carcinoma
have you
gallbladder.
seen many?
Yes, ma'am. We routinely see here carcinoma gallbladders.
Okay, so you think this is a case of carcinoma gallbladder?
Yes, ma'am.
So it's a
Long-standing
case of
pain with
carcinoma. No. You must have known this case. That is why you are very adamant in saying this is a carcinoma gallbladder. Then you
Dr. Khan, what is the age group for malignancy?
age group
Particularly
is
gallbladder or cholangiocarcinoma?
usually middle age and older age, sir.
In your patient,
She's a young female.
No, shall we go ahead with the history? Let us see the rest of the history also after presenting illness.
Yeah, that's
Anything that is
over.
positive for him.
Yeah, I think that's all over, I think, ma'am. Anything else? Was there anything else after that?
No,
Slides?
presenting illness, I think we
Speaking
stopped with the
history.
presenting illness.
Yeah, but otherwise there was nothing significant except for
Nothing
ATT for
significant.
6,
Okay, okay.
except
Then
for
we'll
and
go for examination. We'll see whether he's able to
yeah.
pick up something there.
So if it is benign, what do you think it is? So if it's a malignancy, you thought it is probably a CAGB1. You thought, okay,
Sir, if it's benign, it could be choledocholitis, one, or it could be a Mersey syndrome, sir.
choledocholithiasis. Hmm. So 1 year, and
You
why
should
do you get
explain more about
yeah, yeah,
dyspeptic symptoms and all that.
yeah, do you get progressive jaundice like this?
No, sir. Usually in choledocholitis, we'll get intermittent jaundice,
What
but
else you
it's a
get?
short,
Hmm.
yes, sir.
Short,
But
then
it is short
intermittent.
duration, so intermittent and waxing waning cannot be differentiated on the
Okay,
short
you may
duration.
also have some cholangitis features also, no?
Yes, sir.
Usually. Okay. Anything else? Choledocholitis, anything else?
Sir, it could be Mersey syndrome also, sir, with causing external compression on the bile duct, which is causing
Okay.
this jaundice.
So it's a malignancy. If it is apart from the CAGB, anything else it can be in the malignancy. About cholangio, you said.
Sir, a patient having pain with jaundice, it could be a carcinoma head of the pancreas also, sir, but age,
The 1 year pain. Okay. Can you think of anything else which is causing obstruction of the hilum, like lymph nodes or anything? Something else somewhere? Primary? Still possible?
sir, she has a history of tuberculosis, so portal lymph nodes or some portal lymphadenopathy
You
can
should
also
keep
cause,
that
sir.
also in mind.
Yes, sir.
Anything to do with the colorectal cyst, can you think of? Which can
Sir,
have
yes,
pain for so long and then jaundice
yes,
like
sir.
this?
Could be cholelocystis also, sir, with
So
young
that's
age,
also a
sir.
possibility, no?
Yes, sir.
So you should
If it's
think of
malignancy, is it painless progressive jaundice or painful progressive jaundice? Your case is painful progressive jaundice.
Ma'am, carcinoma gallbladder can have pain, and carcinoma head of pancreas can also present with pain, ma'am.
No, then what causes painless progressive jaundice?
Painless progressive jaundice is typically a feature of, ma'am, distal cholangiocarcinoma and some ampullary carcinoma, ma'am.
Ampullary.
you're also
Ampullary
getting
of
hilar cholangiocarcinoma.
hyalocholangiocarcinoma, yes, ma'am.
Yeah.
Okay, continue.
Any other diseases you're thinking in terms of medical causes? Because she's a young female, you're eliciting all the surgical causes or obstructive causes like mechanical obstruction, like a stone, a carcinoma, or a lymph node. Any other diseases of the liver and biliary tree can present like this?
Considering her young age, sir, non-cirrhotic portal fibrosis can also present like this in young age with jaundice.
Any other diseases which can present like this 1 year history of pain and then progressive cholestatic jaundice? It's a cholestatic jaundice, na?
It's a cholestatic jaundice.
Yeah.
So
So,
primary
to tell, have not only as you have a broad idea about what are all the diseases which cause cholestatic jaundice. Is it true or not? And
yes,
in
sir.
a young patient, you cannot jump and say that this patient can have CA gallbladder because I have seen a patient.
Yeah. Vamshi, your voice, I think there's some network issues with your phone. Vamshi,
That's why she is history.
Sir, can you please repeat, sir?
I think he has some network issues, I think.
Yes,
Yeah,
sir.
yeah, but we cannot agree for the CA gallbladder as his first diagnosis.
So, yeah, except for your weight loss and progressive
Nothing
jaundice
else
for
is there.
30 days. Okay.
Hmm.
Short issue. Okay, fine. Okay, go to the examination now. We'll go to the examination and see. Okay.
Okay, sir.
You should also keep the medical conditions also in. That's what he wanted to say. Dr. Vamshi wanted to tell
Yeah,
you.
yeah.
He wanted to tell us there are some cholestatic conditions which can cause some similar pictures sometimes.
Yes.
Okay. So you should keep that also in mind. Okay,
Okay,
fine.
sir.
You can get some strictures, benign strictures. You can get, like if she has a known tuberculosis, no, can you get some tuberculosis strictures, something like that, benign strictures?
Yes, sir.
Still possible. Okay. Some
Yes, sir.
sclerosing cholangitis, you can get strictures. That's still
Yes,
not a
sir.
malignant one. There may be a long history of recurrent cholangitis. So all this can cause. So you should keep all that in mind. Young girl, no? That's
Yes,
right.
sir. Yes, sir.
Okay. Go to the examination now.
So, sir, examination. My patient is conscious and into the 9+ person. She is of average build and she is poorly nourished. She is well hydrated. Her weight is 36 kilograms. Height is 148 centimeter and her BMI is 16.3 kilograms per meter square. Her Karpinowski performance score is 90 and ECOG is 1. She is febrile to touch. Her pulse rate is 63 beats per minute, which is measured in the right radial artery. It is regular rhythm, good volume. There is no radial or radiofemoral delay. Our blood pressure is 133 by 80 millimeters of mercury, which is taken in sitting position in right arm. Her respiratory rate is 18 breaths per minute. On general physical examination, stress is present. Pallor cannot be commented upon. She has no clubbing, no cyanosis, and no pedal edema. There is no generalized lymphadenopathy, and left supraclavicular lymph node is not palpable. Her neck veins are not distended. Scratch marks are present over the lower abdomen and extremities, and there are no stigmata of chronic liver disease present. Her systemic examination is unremarkable. CNS, there is no focal neurological deficit. GCS is 15, and all power in all four limbs are intact. Respiratory, there is bilateral air entry and normal vesicular breath sounds in both lung fields. S1, S2 is normal, and there are no murmurs. There's no skeletal deformity or no gait abnormality. On per-abdomen examination, there is a mild fullness present at the right upper quadrant. There is reduced respiratory movements also present at the right upper quadrant. Umbilicus is inverted and is in the midline. Scar marks are present, stretch marks are present over the lower abdomen. There is no dilated veins or sinuses, and there is no visible peristalsis present. Hernial orifice, there is no visible cuff impulse. On inspection of the back and spine are unremarkable. External genitalia appear normal. On palpation, the findings of inspection were confirmed. On superficial palpation, there is no local rise of temperature or tenderness. On palpation, there is a globular lump of approx 4 across 4 centimeter size in the right upper on the right upper quadrant in the right hypochondrium. It is palpable
Yeah,
below the
good.
right cost. It is palpable below the right costal margin, just lateral to the lateral border of the right rectus muscle. All margins are well defined except for the superior margin. It has smooth surface. It is hard in consistency and it moves with respiration. Side to side mobility in this lump is not present. There is no rebound tenderness or guarding present. Liver is not palpable, spleen is not palpable, and there are no other lumps palpable. Hernial orifices are intact. There is no paraspinal tenderness. Renal tenderness is not present, and there is no renal angle fullness. Left supraclavicular lymph node is not palpable. Liver span is 11 centimeter in the anterior axillary line. Dull node is present over the lump. There is no free fluid, and bilateral renal angles are resonant. Bowel sounds are present. They are normal. On parectal examination, it is normal. There is no fissure, fistula or induration present. Anal tone and squeeze pressure are normal. There is no growth or nodularity present. Mucosa is freely mobile. Fecal stain is present, which is pale colored. There is no blood stain present or melena present. Provisional was not done as the patient is unmarried. So summarizing my case, lady, age 26-year-old, resident of Amroha, Uttar Pradesh, presented with right upper abdomen pain for the last 1 year with progressive jaundice and passage of high-colored urine and pale stools for the last 30 days with generalized itching for the last 20 days with loss of appetite and unintentional significant weight loss for the last 6 months with no prodromal symptoms and no known comorbidities. On examination, she is ecteric with palpable hard gallbladder lump. There is no free fluid and left supraclavicular lymph node is not palpable.
Yeah. Now with your examination, like what What do you think now? We have discussed with the history, no? Now with the examination, like what are the two positive things that you had?
Sir, on history, the two positive things that I had was long-standing, short duration, obstructive jaundice, and loss of weight and loss of appetite with my history. On examination, I found that she is ectric and there is a hard, palpable gallbladder lump present.
Okay. But you said it's also smooth.
Sir, it is smooth in
Surface is
surface,
smooth.
and side to side mobility is restricted, sir.
Okay. So liver is not palpable.
Liver is not palpable, sir. There's no hepatomegaly, no splenomegaly.
Do you think that is a normal liver span the patient had?
The patient has a normal liver span, 11 centimeter in the anterior axillary line, sir.
Okay. Hmm. So with your examination now, what is your diagnosis now? What do you think it is?
Sir, she has a long-standing history, 1 year
No,
pain
no, just
with
tell what you think, and then you can give me the reasons for that.
so she has a palpable hard gallbladder lump.
Now, what is your
So,
diagnosis? What do you think is your diagnosis?
so for my first diagnosis, I have to keep as carcinoma gallbladder, followed by
It's a malignant obstructive jaundice.
it's
That's
a
what
malignant
you say,
obstructive jaundice, yes, sir.
and probably it's because of
Gallbladder lump, sir.
gallbladder
Why should the
malignancy.
gallbladder cause obstructive jaundice?
It's a gallbladder malignancy you are talking. Hmm?
Yes, ma'am. Yes, sir.
Yeah, why
Gallbladder
should the malignancy in the gallbladder cause obstructive jaundice?
Malignancy in gallbladder lump can be caused by either the external compression by the gallbladder mass
External compression of the gallbladder on what?
on the common bile duct, or it could be a direct infiltration. Ma'am, there could be portal lymphadenopathy also, which can cause obstruction, and there might be concomitant metastases which are causing liver failure and obstructive jaundice in this one.
They have done investigations for this patient, and the patient has been diagnosed as the gallbladder, is it?
Yes, ma'am. The CCT has been done, ma'am.
Oh, so you're presenting this case because it's a rare one, right?
According to her age, it is young case, ma'am.
Yeah, young patient with CA gallbladder. That is why you're interested in presenting this case.
Okay, apart from
Because this is usually a rare one, but you're trying to present that. That is what. Otherwise, we'll take the discussion towards this. That is why.
Yes, ma'am. It is kind of yes, ma'am. It is rare to find a gallbladder
Okay, so
malignancy
you
in such a
wanted to
young.
present that.
Yes, ma'am.
You wanted to present a rare case. Okay.
oh,
So why do you say this is a case of carcinoma gallbladder? As sir asked you, why do you want to say this is carcinoma gallbladder?
So first thing, it is obstructive jaundice is there with the loss of weight and loss of appetite, plus a palpable hard gallbladder lump, ma'am, which has a restriction of mobility. So a
But then,
gallbladder.
as sir pointed out, you said smooth. The surface is smooth. Go to the
Yeah,
Yes, ma'am. The
palpation
surface is
one.
smooth.
so do you think what you're palpating is the malignant gallbladder? Is it the malignant mass that you are palpating? You said smooth surface. Okay.
Yes.
Hmm.
other differential diagnosis you have in your mind, because you are palpating gallbladder and you are directly telling that it is CA gallbladder.
Other diagnosis can
Yes.
include other diagnosis can include periampullary carcinoma or carcinoma head of pancreas or distal cholangiocarcinoma also, sir.
Now, how common is carcinoma gallbladder when compared to carcinoma pancreas?
In North, carcinoma gallbladder is more common as compared to carcinoma head of
Yes,
pancreas.
that is true. It is common, but that doesn't mean that it has to be. It is only common. Nobody said that it is.
Yes, ma'am.
You know the difference between common and always.
Yes, ma'am.
Okay, what
Yes, tell me then.
you can elicit or tell or keep in your mind, the gallbladder is palpable. What are all this where gallbladder is palpable?
Can you repeat the question, sir? I was not able to hear it. That
what are all the diseases or diagnoses which gallbladder will be palpable?
Sir, it could be mucocele, sir, where the gallbladder can be palpable. It might be a pyocele, sir, where gallbladder can be palpable. It could be a gallbladder lump
Pyocele,
following
you
a...
said?
Ma'am, pyocele.
Pyocele. Mucocele or pyocele?
Mucocele, ma'am. Mucocele and pyocele is when pus forms.
Okay. So when the pus is there in the gallbladder, you call it pyocele. The mucocele becomes pyocele. Okay, carry on. You don't call it empyema.
Empyema gallbladder.
Pus in the gallbladder is called pyocele or empyema?
Empyema gallbladder, ma'am.
Okay, carry on.
Other conditions include, sir, post an episode of acute cholestasis, a gallbladder lump can be present, sir.
Acute
Post an acute
calcitis.
calculus, yes, sir.
Okay. Any other?
Sir, any distal obstruction of the bile duct, including periampullary carcinoma, carcinoma head of pancreas, or distal cholangiocarcinoma, a palpable gallbladder can be present, sir.
Okay. So if you keep all these diseases in mind, and if you say that whatever I am palpating is a gallbladder, all the findings which you have elicited, like the all margins are well defined, smooth, hard in consistency. So keeping these findings in your mind, what are the diseases which you can filter?
So keeping hard in mind, because usually in a case of distal obstruction, the gallbladder will be firm, not hard in consistency. So first thing that we can rule out is a distal obstruction. Second thing, this mass is not tender. That lump that I'm able to feel is not tender. So I can rule out empyema.
So as it is not tender, you can rule out all the acute causes like acute calculus, cholecystitis,
Status.
mucocele, all
Yes, sir.
these things are excluded. Okay.
Yes, sir.
Is it true?
Yes, sir.
Okay. What is Courvoisier's law?
So Courvoisier law states that in a patient of obstructive jaundice with palpable gallbladder, it is seldom due to stones.
Okay. Can you specifically mention about what is the actual law?
Sir, actual law states that in a patient of jaundice with, if the gallbladder is palpable, it is seldom due to stones.
Soft, non-tender gallbladder.
Okay, sir.
These are the words you should use. What is it?
Okay.
Can you repeat?
So, in a patient of jaundice with a soft, non-tender palpable gallbladder, it is seldom due to stones.
Yeah. So can you apply this here and then tell me?
So if applying this law, it is a hard consistency gallbladder.
So the applying the Courvoisier's law, what will be the diagnosis?
Sir, if applying the Courvoisier law, we can think it either of this as a periampullary tumor or carcinoma head of pancreas or a distal cholangiocarcinoma.
And what are the exceptions of this Courvoisier law?
Exceptions of Courvoisier law include, sir, a double impacted stone with one stone at the neck of the gallbladder and one stone at the distal bile duct. Oriental cholangiohepatitis means worm in the gallbladder, worm in the biliary tree, and
if there's a single stone is there, can it happen?
a single stone is there, it couldn't happen, sir.
Where,
like if the gallbladder is
single stone? Where will be that single stone?
Single stone will be stuck at the neck of the gallbladder, causing external compression of the common hepatic duct and
Then
also
how it will
occluding
cause jaundice here? Then how it will cause the jaundice?
So by the external compression of the common hepatic duct, sir, it will cause jaundice, and this stone will be restricting the opening of the gallbladder also, so it will cause a distended gallbladder also.
Single stone will be at the terminal end of the bile duct. Okay, so there will be proximal dilatation both of the bile duct causing the jaundice,
Yes,
and
sir.
also the dilatation of the gallbladder.
Yes, sir.
Okay, so either double impaction or single impaction at the terminal end of the bile duct.
Okay, sir.
You said you have measured the liver span in this patient. It is 11 centimeter, isn't it?
Yes, sir.
13. 13 or 11?
11, ma'am.
Yeah,
11.
11.
Okay. Mm.
Good. Achha, it is in the anterior axial line.
Anterior line, sir.
Hmm?
Yes, sir.
Why did you do it in the anterior axial line?
So because in the mid clavicular line, the lump was there.
Okay,
The
good.
lump was
So is 11 centimeter a normal liver span in anterior axial line?
sir, in the anterior axial line, the liver span is usually 11 to 13 centimeters, sir.
It's more, yeah. It's around 13 to 15 centimeter in the
13.
anterior axial line. जो है ना?
Yes, sir.
11 to 13 in the mid clavicular
Mid
part.
clavicular line.
Now tell what are the causes of jaundice in a patient with a CA gallbladder?
Causes of jaundice in a case of CA gallbladder might include sir, external compression of the common hepatic duct by the mass, infiltration of the common bile duct or the common hepatic duct by the mass, portal lymph node or portal lymphadenopathy causing the external compression, concomitant presence of a choledocholithiasis or liver metastasis, which can cause jaundice.
So do you think there will be one or two liver metastases that can cause a jaundice?
So usually it is extensive liver metastasis which causes jaundice, but a single caudate low metastasis which is big enough can also cause compression of the bile duct, sir.
If it is single, it is usually in the caudate lobe. It will be there.
Caudate lobe, sir.
What is the chance of having the choledocholithiasis in CA gallbladder?
So it is less than 3 to 5% cases we will see.
And what is the chance of having the gallstone in the CA gallbladder?
It is 70 to 80%, sir.
What is xanthogranuloma cholecystitis?
Xanthogranulomatous cholestasis, sir, is a chronic inflammatory condition with like it's a chronic inflammatory condition with the deposit of the cholesterol, sir, in the gallbladder wall. So it will cause thickening of the gallbladder wall, sir.
So what is the clinical significance of that?
Clinical significance is, sir, it can mimic a case of carcinoma gallbladder, sir.
You know,
With
many times
gallbladder.
that comes as a differential diagnosis.
Yes, sir. Yes, sir.
So how can you clinically differentiate whether it is a xanthogranuloma or carcinoma?
So clinically, sir, usually jaundice will not be there first thing in a case of xanthogrammatis cholestatis, though it can be there. Second thing, this lump will not be hard; it will be firm in consistency. Third thing, sir, restriction of mobility will not be there, sir. It will be mobile lump.
So that is, locally it will be very difficult to differentiate because that will
Yes.
be also like a firm to hard lump which will be there.
Yes, sir.
It is only the associated features which are there. Okay. In the
Yes,
case
sir.
of carcinoma gallbladder, like in your patient, there is a loss of weight is there, loss of appetite is there.
Yes, sir. Yes, sir.
And those features are not there in the patients with the
Xanthogrammatis cholestatis.
xanthogranuloma. The patients are rather obese patients, those patients, or
Yes,
fatty
sir.
patients, those.
So clinically and history-wise, we cannot differentiate xanthomatous xanthomatous changes with carcinoma of gallbladder.
Yes, sir.
Okay,
Yes, sir.
it's very difficult.
Okay, doctor.
Yes, sir.
Yes. Go to the general examination.
Yes, sir.
Now, why didn't you mention about the level of consciousness and orientation?
She is conscious and oriented.
Conscious, okay. Conscious and oriented. Yes, is it important here in this case?
So, ma'am, she is a case of obstructive jaundice likely. So, consciousness and orientation needs to be mentioned because she might be in cholangitis. A cholangitis patient usually will be drowsy, ma'am.
Cholangitis causes unconsciousness
Drowsy,
or
ma'am.
cholangitis causes all that. So what is triad then?
Triad of cholangitis is, ma'am, intermittent pain, intermittent fever, intermittent jaundice. In severe cholangitis, a renal pentad can be seen, which is including hypotension and reduced consciousness or drowsiness.
So here it is very, very important to mention about the level of consciousness, right?
Yes, ma'am. Yes, yes, ma'am.
More than the other cases.
Yes, ma'am.
Okay, go to the next one then. Next. Icterus present where?
Ictus, ma'am, present. I examined the patient.
You will
Ictus
have
was
to
present.
tell us that.
It was
Okay.
present on sclera. Yes, ma'am.
You will have to tell us about that. Okay.
Okay, ma'am.
Yes. Next. Scratch marks present. Okay. Next. The no stigmata of chronic liver disease. Then
Yes,
again,
ma'am.
you'll have to tell us what exactly you meant by that.
Yes,
Okay.
ma'am. Yes, ma'am.
Why neck veins not distended? What is the significance of that?
Ma'am, if the patient is having hepatomegaly or patient is having jaundice secondary to cardiac failure, neck veins might be distended.
So for any patient, you are going to talk about cardiac failure. Or in a case of jaundice alone, you're going to talk about neck veins.
Ma'am, if
Liver failure
is...
patient goes on to cardiac failure, is it?
Yes, ma'am.
Yes. That means all the patients are going to go for cardiac failure before they die.
No, ma'am.
Chronic cases. Yes, I don't know whether you're taught that way, but usually we don't mention. Okay, next. No focal neurological deficit. Will there be any focal neurological deficit here
Ma'am,
or general?
general deficits will also be
It is
there.
more
Like
of general than your
more...
focal.
Yes, ma'am.
Okay, go to the next one then. So as I told you, you'll have to mention about the quadrants.
Quadrants, ma'am.
Okay.
Right hypochondry. Yes, ma'am.
Yes, yes. Next.
How much time do you have, sir? Actually,
Next.
We have another 15 minutes time left for the discussion.
Then I
Yes,
think
yes,
we'll go
yes.
to the evaluation, sir. Otherwise, ma'am, just finish,
Yeah,
ma'am.
yeah, but
We'll go
he
to the
has to
evaluation.
know
Yeah, you
that
finish, ma'am.
he has to know
Yes,
that
ma'am.
if he is not going to mention about tenderness, he
Yes, ma'am.
cannot mention about rebound tenderness.
Sure, sure. Yeah.
Yes,
Yes, ma'am. It is a tender lump.
there was tenderness or not?
It was
There
not
is-
non-tender, ma'am.
Not then why do you talk about rebound tenderness?
Yes, I
Okay,
mentioned
carry
first
on.
about...
So these are the basic things that you should know before you go for discussion.
Yes, ma'am.
You understand? Only if you tell all these properly, we can go for discussion. Liver is not palpable, spleen is not palpable, no other lump palpable. What lump did you palpate for?
Ma'am, it could be a lymph nodal mass
What
or
the?
some other lump that could be present.
Some
ma'am.
other lump. What lump? Ovarian lump, uterine lump. So you should be more specific. You cannot
Okay.
just say no other lump. Maybe you're talking about nodes, paraaortic nodes. Okay. So you
Yes,
should
ma'am.
be more specific. If you say liver, then spleen, then why do you want to talk about any other lump? You should know what lump you're talking about.
Yes, ma'am.
Got it?
Yes, ma'am.
Yes, next. Dull node present over lump. So here percussion, liver, you never mention anything about liver. Liver also you're supposed to percuss, no?
Yes, ma'am.
So on percussion, the liver span was 11 centimeters.
Yes, ma'am.
Okay. Dull node present over the lump. No free fluid. Renal angles are resonant. Normal bowel sounds present. Bowel sounds are present normally.
Normal bowel sounds are there, ma'am.
Okay, carry on. Next. Okay, all this is okay. So these examination, palpation, inspection, it should be more accurate. Okay.
Yes, ma'am. Yes, ma'am.
Yes, next. Yes. I think as others suggested, we can go for discussion now.
Yeah. Now with your probable diagnosis, what you have probable differentials, how will you go ahead with this patient now?
Sir, first I will go for a ultrasound of the whole abdomen, sir.
You don't want to confirm whether it's a obstructive jaundice or not? You don't want? You don't want any other investigations?
So I will go with for a LFT also, liver function test.
Okay. No hemogram, nothing. Okay,
Sir,
you
liver
are
function
okay.
test.
You want to go diagnostic, you want to have LFT and ultrasound abdomen. Okay.
Yes, sir.
So, okay. Do we have, sir, the investigations? Anyone we can have?
Sir, I have the ultrasound whole abdomen of the patient, sir.
Yeah.
Sir, liver is enlarged 13.5 centimeters and an ill-defined heterogeneous hypoechoic area of 5 cross 4 centimeters seen at the segment 4B of the liver with moderate bilobar IHPRD. Gallbladder is distended and it is asymmetrically heteroechoic wall thickening with maximum thickness of 9 mm with the loss of fat planes with segment 4B and 5. CBD was not dilated, portal vein was not dilated, spleen is 8.5 centimeters size, and pancreas is normal, sir. They gave an impression of neoplastic gallbladder wall thickening.
So then what do you think is in the liver then?
Sir, in the case of obstructive jaundice, if there is heterogeneous hypoechoic area, first thing that will come to mind will be first will be metastasis. Second, it could be a cholangitic abscess or hepatic abscess also, sir.
What are the features of CA gallbladder on ultrasonography?
Sir, features of CA gallbladder on ultrasonography will be a thick wall gallbladder more than 3 mm wall thickening, which is asymmetrical, and there is loss of demarcation and loss of planes with the liver. There might be presence of lymph nodes in the portal region or in the interaortocaval region. In addition, there might be bile duct obstruction, which might be seen with bilobar HBRT and central HBRD. In addition, we have to look for any mass in the liver and the free fluids, sir.
The polypoidal mass in the gallbladder, in the lumen, the gallstones.
Gallstones.
Then what other things you are missing in this ultrasound? Which, if it is a case of malignancy gallbladder, then the ultrasonologist should have mentioned about that.
Sir, the ultrasonography should I mention about shear wave elastography and the vascularity of this wall thickening, sir?
Simply, I'm not asking the elastography as such. A simple ultrasound. A patient is having carcinoma gallbladder suggestive on ultrasound. What are the other things which are not there in this, which you are showing me?
Why are you interested in elastography in this case?
Sir,
do you think you routinely expect someone to give you elastography?
No, sir. If it's like symmetrical wall thickening, then a shear wave elastography has a role. Otherwise, it doesn't have a role.
If the patient has ascites, how does that matter?
So patient has ascites, either it could be nutritional, secondary to some peritoneal
Still,
deposits.
I can say that this is a case of inflamed gallbladder, and the pancreatic lesion is not seen in a ultrasound. Now, how do you say?
Ma'am, CBD is not dilated, ma'am. That is one thing against. There is
Okay,
bilobar.
the CBD is...
IHBRD is there, but CBD is not dilated.
That is not dilated also.
That? In a case of CA gallbladder, how do you explain that? The CBD is not dilated, but the patient is having jaundice.
Sir, it could be a port.
Yeah.
Sir, it could be infiltration at the level of hilum, or it could be a portal mass which is obstructing the bile duct.
Yeah, that is a common.
Then IHBR dilatation must be more. Here it's only moderate.
IHBRD is there, but if the CBD is not dilated, the reason for that is because the port metastasis is there. Okay, you are right.
Sir, we also have the blood investigations for patients, sir.
Okay.
Have we done more investigations other than this?
Sir, ma'am, we have a CT scan of the patient also.
MRCP2. What are the investigations?
CT scan is there, and CT of thorax,
Okay.
abdomen,
CT
pelvis.
also says this.
CT shows a heterogeneously enhancing lesion in gallbladder of size 3 cross 3.1 cross 3.1 centimeter, and is infiltration into
Okay, it
segment
confirms.
4B and 5, and loss of fat planes with duodenum and hepatic flexure. Also, a ill-defined nodal mass in the porta of size 2.2 cross 2.2 centimeter, causing mass effect on common hemorrhagic duct and the floor of confluence with upstream dilation.
So it's a porta hepatis node that is causing the dilatation of the IHBR.
Yes, ma'am, it is causing mass effect on the confluence, involving the floor of confluence.
Okay, good. So we have not been able to, you have not been able to diagnose the case of obstructive jaundice. Yes, with only the investigations we are able to know about the gallbladder mass, right?
Gallbladder mass, ma'am. Ma'am, on palpation also it was a heart lump, but differentiation was
Even in
difficult.
palpation, anything, when there is a inflammatory mass and the bowel is there, going to, what is the rumentum is going to be there, it's going to, on palpation, it's going to be hard only.
Yes, ma'am.
Yes.
To evaluate this patient with these findings?
Sir, we have a, CT of abdomen, thorax, and pelvis, and we have blood investigations. The patient is not in cholangitis, but there is a cholangitic abscess slash metastasis present in segment 7 and segment 8. If the gallbladder mass is there, it is locally advanced. So first we'll go for biliary drainage, sir,
Okay,
followed
go for
by
blood investigations.
blood investigation, sir.
Okay, interpret this LFT.
So in this LFT, the total bilirubin is 13.2 and direct bilirubin is 7.98, which is raised. Direct bilirubin is more than 15% of the total, so it is obstructive jaundice. SGPT and SGOT are normal. ALP and GGT are raised, which
SGPT.
SGPT is mildly raised to 74. Normal range is still 60 to 65 in our institute, sir.
Okay.
ALP and GGT are raised. ALP is 910 and GGT is 120. Which indicate there is cholestasis. Hemoglobin is 7.5 and the total counts are 8,000.
Okay.
Also, the PT and INR are normal. The PT is 11.4 and the INR is 0.99. The KFT is normal. CA99, we did a marker, it is raised. It's raised 63,900.
So why you have chosen only CA99 and why didn't you choose any other tumor marker?
So CA99 is more specific for biliary malignancy, though in this patient, as she is having obstructive jaundice, CA99 will not be valid. CA has not been done yet. CA report of this patient and CA125, which are the other markers for biliary malignancy, are pending, sir.
Okay.
Okay, the direct bilirubin is 7.8 or 9.
7.98, ma'am.
Okay, almost 8. So and the total is 13.
13, ma'am.
What about the rest?
The SGPT is 74, ma'am. SGOT is 10. ALP is 910 and GGT is
So is the liver
120.
affected or not?
The liver
Liver
is not
function is affected or not?
the liver function is not affected, ma'am. Her albumin also was normal. Albumin was 3.6 in this patient.
Then
Also,
why direct bilirubin is only 8? Another 7 is indirect. What does it mean?
It means that more than 50% of the total bilirubin is direct bilirubin, which means it is obstructive jaundice, ma'am. It is a post-hepatic
Okay, the
jaundice.
rest?
The rest, ma'am, the transaminases are normal, the SGPT and SGOT. That means that
Is the liver function, so the liver function is not affected at all.
Yes, ma'am.
Not affected at all, sure. The gallbladder, it is malignancy of the gallbladder. The nodes
Yes,
are
ma'am.
all there. The node has caused what compression of the porta hepatis. Then IHB are all dilated.
The ma'am, liver function will be affected, but it will show up late into the liver function test.
Now, what
When
is this indirect bilirubin raise because of? Is indirect bilirubin raised or not?
it is raised, ma'am, means
Doctor,
Then what
conjugation
is it
is
due to?
altered now. How can you say
reduced, reduced conjugation.
Is it normal or altered, as sir said?
It is altered. It is,
the entire liver function tests are altered, doctor?
yes.
The ALP and GGT are elevated. You have bilirubin elevated. The entire excretory function of the liver is affected, and she is in cholestatic jaundice. Okay, if you say the patient is in jaundice, do the liver function is affected or not?
Liver function is affected, sir.
Then okay, shall we go for the next
Yes,
investigation?
yes.
So until now you have done an LFT in blood investigations and have done a CT and ultrasound, and
Yes,
we
ma'am.
have these findings. And next, what you want to do with this patient? You have these in your OPD, and the patient is in front of you, and then what you want to counsel the patient?
Like I have a patient who is having obstructive jaundice with enhancing lesion in the gallbladder, which is likely malignant. With the obstructive jaundice, I will first like to counsel like regarding the prognosis of the disease. Second, I will like to do biliary drainage under the cover of antibiotics after proper hydration and correction of the coagulopathy, sir.
So you want to tell the patient what you want to tell the patient. Patient will ask you what disease I am having. Before contemplating a drainage procedure, which is an intervention, he will definitely ask what is my disease. What do you want to tell the patient?
Sir, it is an enhancing lesion. It could be either a mass, which is either malignant, or could be xanthophylamatous cholestasis also, sir.
Stones.
What's your intention for biliary drainage?
Sir, so
Why do
biliary
you want to do
obstruction is
biliary
the,
drainage here?
so like biliary obstruction is there, which is causing features first itching and this and so excretory function of the liver is deranged, sir. So I'll ask for a drainage, sir.
Okay, it's for the quality of life or anything else?
So to prevent infection also, because it is stagnant bile.
As of now, there is no infection, no?
No, sir, no infection as of now.
By doing a drainage procedure, you want
No,
to
you want to infect it by entering into this thing.
it's a sterile area.
Yes.
Now, what's your intention of doing biliary drainage? One is quality of life. You want to bring down the pruritus and all that. Then what is your next aim? What's your plan for this patient?
So for this
It's a
patient,
locally
as
advanced. It's a locally advanced.
locally advanced, sir. Plus,
Do you
if
think it's
she has a
do you think it's
cholangiotic abscess.
resectable? Are you planning for a resection or not? Resection or something else?
The only problem in this patient was that on CACT there was a heterogeneous enhancing lesion in the segment 6 and 7, which was either a cholangiotic abscess or a metastasis. So we want to drain it and give a patient a trial of antibiotics to resolve that cholangiotic abscess.
Okay, but otherwise, do you think it's resectable without that 2 lesions in the liver?
Otherwise, also, sir, it is currently not resectable, sir. It is a
So
locally
what's your plan?
advanced.
If it is not resectable, then what's your goal
So
of
how do you
treatment?
know that it is not resectable? You've done an investigation, CT.
Ma'am, it is showing loss of
What
fat
makes you
planes.
think that loss of fat plane? So
Loss
that
of
is why
fat,
you are saying that it is not resectable, right?
lot of loss of fat planes to two adjacent organs, ma'am, duodenum and
Okay.
hepatic flexure, ma'am.
But still you want to do a drainage procedure.
So
Can
when
you
it's
do
not
any other
resectable, what's your next
investigations
step?
to
Yes,
confirm your
yes.
diagnosis?
We
Now
can go
what do
for
you want to
Can
drain?
you do
What
any
do you
other
want to drain?
investigation?
The
Yes, other
bilevel
than
eyes,
CT.
we can go for a MRI, ma'am, to differentiate it. That it
MRI
is
or
a
MRCP?
MRI plus MRCP, MRI abdomen plus MRCP, ma'am, to delineate the biliary to see the level of obstruction and
So
also
you're
see
going to do
about
MRCP and MRI or MRI and MRCP.
MRI abdomen plus MRCP, ma'am.
So you want to know more about the biliary tree or about the abdomen now?
The ma'am, more about biliary tree, ma'am.
Okay, so which investigation then you are supposed to say? Ultrasound, you're going to do basic investigations, all those bilirubin, CBC and bilirubin, left teeth.
Yes, ma'am.
Other than that, you're going to do an ultrasound, then
Yes,
your
ma'am.
CECT, then your MRCP, and then MRI of the abdomen. Okay. Now,
Yes,
what do you
ma'am.
want to drain? They've asked you, why do you want to drain? Now, what do you want to drain, first of all?
The patient had a cholangitic abscess, ma'am. That is an indication for drainage because it was
Cholangitic abscess.
abscess.
Where is the abscess?
Segment 6 and 7. It was
Okay, how are you going to drain? Which one you're going to drain?
Anything suggestive of any abscess? The patient has any fever, counts are high, anything?
no, sir.
Then why do you think it's an abscess?
Ah,
Why do you want to drain it now?
Clinically, sir, like clinically, not like radiologically, it was more suggestive of an abscess rather than a metastasis, sir. There was no peripheral ring and acid present. Also, on ultrasound correlation, sir, that ultrasound correlation was done. It also showed that this lesion didn't have any vascularity.
okay, how are you going to drain? Going to do an INT?
No, ma'am.
Cholangitic abscess. Is the
Cholangitic abscess.
cholangitic abscess causing obstruction and what is that? Bilirubin raise, jaundice.
No, ma'am. It is the bilobar
Ah,
IHPRT and which is causing the jaundice, which is secondary
okay,
to a nodal mass at the
this
porta.
is secondary to, okay. So this is secondary to obstruction. So you
Yes,
want to
ma'am.
drain the obstruction or you want to drain the cholangitic abscess?
I will like to drain the we will drain the obstruction, ma'am. The obstructed
Okay, so
biliary
where
system.
is the obstruction and how are you going to drain?
The obstruction is at the porta, ma'am.
Okay,
So percutaneous transhepatic biliary drainage will be preferable in this patient, ma'am.
so you want to do a PTBD.
Yes, ma'am.
PTBD, right?
Yes, ma'am.
Why
Okay,
can't
so
you drainage?
So it is a high obstruction. Also, like in the screening, the IR, all medical gastroenterology said that it is not drainable by a stenting. Like stenting is not possible in this lesion. So they
Why?
asked for a percutaneous transhepatic biliary
see,
drainage also.
no, but we are talking about general. Generally, how do you
Generally,
drain?
ma'am, ERCP
Mm.
and stenting is preferred, ma'am.
Mm. Yeah, CP and stenting is preferred. Yes, if it's going to be a distal obstruction,
Distal
because
obstruction.
here there is proximal obstruction. You want to go proximally and drain the biliary tract, right?
Yes, ma'am.
Okay.
Any place of PET scan in your patient?
Indication
No,
for which
Yeah.
scan?
a PET scan, sir, indication was first this cholangitic only abscess only, sir, to characterize this
So in
abscess.
your
This
case, to differentiate whether it is a xanthogranuloma or whether it is a malignant one,
yes,
can be differentiated with a PET scan. Whether those abscesses, it's a metastasis or it is a simple abscess is there, that can be
yes, sir.
differentiated. You know?
Yes, sir.
So your patient probably requires the PET scan to confirm that. And then you have to do certain endo investigation in this patient. You know? You have to do the endo ultrasound. Because if you find this patient is not an operable patient, you have to confirm the diagnosis before you give some chemotherapy or something like that to this patient.
Yes, sir.
So one of the ways is that you can go with endoscopic ultrasound that you can,
Endoscope.
yeah, you can do the FNAC from there and confirm the diagnosis whether it is malignant or benign one.
Yes, sir.
So
Yes.
where do you place the camera? And I mean, endoscopic ultrasound, where do you place it? Transducer.
So, ma'am, transducer are two types. There is a linear transducer also, and there is a radial transducer also. While
Mm.
if you're doing a FNA, it is usually a linear transducer array
Mm.
through which the needle is guided.
Mm. Where do you place the transducer? I said.
Transducer is placed on duodenum or
In the duodenum or the
transgastric region.
okay,
In the
or the
antrum.
antrum, the stomach.
Antrum.
Yes.
Yes, ma'am.
Okay. From there, can you go all the way and take a thing? What is that? FNAC from the gallbladder. In between, there is nothing. So, what is the diameter of what is that? Wherever you can go, what is the radial diameter from where you can take an FNAC? I mean, all around you can see all around. What is the diameter that you can see view in an endoscopic ultrasound?
I don't know, ma'am.
It is around 8 centimeters. So 8 centimeters all around you can, and then you cannot just put a what needle just into the gallbladder. There are other structures also.
Yes, ma'am.
Yes.
Yes, ma'am.
So it is going to be difficult for you to go for a FNAC of the gallbladder unless the gallbladder is very close. As you said, the gallbladder can cause compression on the
duodenum.
duodenum. You said something else initially. Hepatic tract, you said, I think.
Hepatic
Causing
friction, ma'am.
jaundice. Causing. If it is going to be that, then it is easy for you to take an FNAC, right?
Okay, ma'am.
Okay. So you just give an FNAC and then even then you go start a chemotherapy.
Chemotherapy by either
Yes.
adjuvant or adjuvant palliative intention, ma'am.
Okay. Palliative
FNAC was
intention.
done, transluminal FNAC was done in the patient, ma'am, this patient.
This patient, good. Very good.
And it was inconclusive. Two FNACs were
Inconclusive.
inconclusive. So we went for a core-needle biopsy of this patient, which is through the
CT.
transabdominal CT-guided transabdominal
Okay.
core-needle biopsy, which showed adenocarcinoma with a squamous differentiation.
Okay. I see. Okay. Okay. Good. You've attempted so much, so
If
many
suppose-
investigations.
If suppose this patient is not having any lesions in the liver, okay,
Yes, sir.
then how do you approach this patient?
So, if the patient is a non-metastatic, locally advanced gallbladder carcinoma with obstructive jaundice, first I would like to drain the jaundice, followed by coronal biopsy or an FNAC to prove it is malignancy, followed by
What biopsy you want to do?
not coronal biopsy, sorry, FNAC or a CT-guided coronal biopsy. Those CT-guided coronal biopsy can cause seeding of the tract.
Okay.
But
This FNAC not cause any seedling?
FNAC, if it's done through the transluminal route, the risk is less, sir.
So it is endosono and biopsy is more, it is the protocol of the day. Okay. It
Yes,
is not transabdominal. You should not do any FNAC or core needle. Okay.
yes, sir.
Should not do. Okay. And then if you consider this as locally advanced, you want to go for neoadjuvant therapy and then go for
assess for resectability, sir, after 4 cycles.
okay. This core needle biopsy, if at all it comes as same as adeno-CA with squamous differentiation,
Yes,
any
sir.
other investigation you want to do before sending for neoadjuvant therapy? We'll do a PET scan.
We'll do a PET scan, sir.
Rule out distant metastasis.
We'll have distant metastasis.
Okay.
Yes, sir.
Okay, what if suppose this patient is having nodes that why do you want to send the patient for neoadjuvant therapy? Why can't you operate upfront if the patient is not having any lesions in the liver?
Sir, if a patient with this big mass with a portal,
He already said the loss of fat plane.
Loss of a big portal mass with loss of fat planes, R0 resection might not be possible.
Okay. I want to do a right hemicolectomy and a Whipple's and a radical cholecystectomy. Do you object to the idea of doing this in this patient?
So first thing, it will be a very morbid procedure with high mortality. Second thing, such radical resections in a gallbladder carcinoma is not associated with improved or overall survival.
Okay, next time after sending for neoadjuvant therapy, patient comes back to you with after 4 cycles. Then how do you approach this patient?
Sir, we'll repeat a CACT scan to assess any change, if it's a progressive disease or a stable disease, or there has been any clinical response.
You want to do a CCT or a PET scan?
CCT for local invasions, like how the local things have changed. PET scan can be done to rule out any distant metastasis which has developed during these 4 cycles.
And you find still the duodenum is involved, what do you do?
Sir, if we think that patient can stand more morbid procedure, we will go ahead and operate. Otherwise, if the patient clinical status is not good, we will continue a palliative intention chemotherapy.
Okay, if this is just confined to the gallbladder, what is the management?
Management, if it's just confined to the gallbladder, is a radical cholecystectomy, ma'am.
What is that?
Radical cholecystectomy is the in-block resection of gallbladder with a 2 centimeter wedge of liver or segment 4B5 with the dissection of all the lymph nodes in the hepatoduodenal ligament, which includes level 8 and level 12, and the level 13 retropancreatic lymph node with or without biliary resection.
If it is just confined to the gallbladder, you're going to do so much.
If it's just confined to the gallbladder, ma'am, I'll just do radical cholecystectomy with the dissection of the lymph nodes in the hepatoduodenal ligament.
With dissection of?
Lymph nodes in the hepatoduodenal ligament and level 13 lymph
Hepato?
node. Duodenal ligament, ma'am.
I never said there are nodes anywhere. I just said if it is confined to the gallbladder.
A sampling of the nodes is important for staging, and at least 6 nodes should be sampled for adequate staging of the malignancy, ma'am.
So you're going to go around, pick up all the nodes.
Doctor, hello.
Yes, ma'am. Yes, sir.
Is there any role for D-lab and do a laparoscopic ultrasound?
Laparoscopic ultrasound can be done to see for many metastases in the liver which are not seen on the CACT and the PET
You have to
scans.
say that is also an important. You guys, they said US, then you must say I will do a D-lab, sir. Then I will look for the metastasis and take a biopsy. If there's a doubt, you have other option. You can do a laparoscopic ultrasound. You can see every year, right?
Yes, sir.
US only 6 centimeter radius, 6 to 8 centimeters. Whereas in D-lab, you can go up to where, right? So you have to say, I will do D-lab and do the facilities available. I will do laparoscopic ultrasound and proceed, sir. Go ahead. Right. So far, you are very good. Go ahead.
Okay.
Is there any role for photodynamic therapy here?
Photodynamic, ma'am, I have read 2-3 reports of photodynamic therapy being tried, but I'm not very sure of like how they
Can
go
we
through
try
and
or
how.
not? See, we are supposed to know about recent advances.
Ma'am, in such
Yes,
a
robotic
in such
surgery
advanced,
we talk about. Yes, is there any role or not?
Advanced stage malignancy T4 disease with 2 organ invasion, I don't think so, ma'am, there is a role.
Okay, so you don't want to go ahead with photodynamic therapy. What other therapy is indicated?
And we can go with a neoadjuvant chemotherapy plus radiotherapy. The newer trials are saying neoadjuvant chemoradiation also. The SWOG trial has come, which are mentioning about neoadjuvant chemoradiation also in such patients.
Yes, chemoradiation also, right, for locally advanced. Good. So it is again a multimodality.
Yes, sir.
Right?
You want to do transplant in this patient if at all patient accepts. There is a donor and patient is accepting for any amount of risk she is willing to take, and then money is not a problem, you want to do a transplant in this patient?
So local recurrence is high.
Will you do it or not?
Is it confined to one segment here?
It is confined to 2 segments here only, ma'am.
So are you thinking of liver transplant?
Not for this patient. I will better go with the hepatectomy, ma'am. Right hepatectomy or right extended hepatectomy if functional liver remnant is there.
Okay. Now, if there is ascites,
Ma'am, ascites could be due to 2 reasons. First could be nutritional. Second could be malignant ascites. If malignant ascites is there, it indicates there is a peritoneal dissemination of the disease. In that reason, in that case, a radical resection or such treatment is not beneficial. Patient usually goes for palliative treatment in such cases.
okay. But usually the liver is enlarged, no, in cases of obstructive jaundice and all that.
I usually ma'am, it is enlarged.
Why is it not enlarged here? Have you diagnosed it too early?
No, ma'am.
Or still the intermittent pain that the patient had? Yes? Could it be due to stones?
It could be due to. But ma'am, there is a large portal mass also.
No, initially you said.
Initially, it could be due to stones. When the initial pain that patient was having could be due to stones. Secondly, patient might be having a concomitant biliary cirrhosis also. That's why the liver is not enlarged in this case.
Okay. So did you look for what is that? Sister Mary Joseph nodule?
Sister Mary Joseph nodule is not present in this case.
But did you look for it?
Ma'am, look for it in the umbilicus.
Have you mentioned?
I have not mentioned the Sister Mary Joseph nodule.
Should you look for Troisia? What is that?
Suprachiasmatic
Irish nodule?
Should we look
should
for?
You look for? You should have looked for. Yes?
Look for. Yes, ma'am.
Yes. Okay. I think you discussed the case well. You have prepared well. Good.
Okay, thank you.
What about the others, sir?
So my conclusion is whenever in the exam a case is kept like this, my advice is not to jump to a diagnosis.
Okay, sir.
First thing you have to keep in mind. And whenever an examiner asks what are the differential diagnosis, don't tell the exact pathological diagnosis.
Okay, sir.
Okay. You can tell I am thinking in terms of biliary pathology. If at all you are not sure about what is it. Okay. If you are not sure about the diagnosis or a provisional diagnosis, you can tell that I'm thinking in terms of biliary pathology, sir. I'm thinking in terms of liver pathology or pancreas pathology. If you tell CA gallbladder, it indicates you know the case. The first thing.
Sir.
Apart from the exam, okay, when you are sitting in the OPD after becoming a consultant, when a patient comes to you like this, a young female, okay, young female comes to you with history of pain and jaundice, you should not think about malignant diseases. Okay, especially in female with cholestatic jaundice, you should think of autoimmune pathology where patients can present like this, like loss of weight, loss of appetite. Okay, so you have to think the medical cholestatic jaundice diseases also, like sclerosing cholangitis, primary biliary cirrhosis, autoimmune. You can exclude things which are present, which are not present in these disorders. Okay, and it is not that you are appearing for a surgical exam, you should tell only surgical diseases. Okay.
Yes, sir.
Whenever you are sitting in the OPD after becoming consultant, which you will probably do in the next year, you should think in a broad way so that you can arrive at a diagnosis and also save the money of the patient rather than doing all the investigations.
Yes.
Like MRI abdomen and MRCP and then CCT, and you will not be having such luxury in all patients.
Yes.
Okay. Scientifically, you have to think and then you have to advise.
Yes.
Okay. Thank you.
Here you saw the case as a case of carcinoma gallbladder and everything You prepared only for that. Okay. So you should have it as a broad one. The most common cause first. Not always you get a case of carcinoma gallbladder. So carcinoma, head of pancreas and cholangio, everything you should discuss. Everything should be should come to your mind, and you should rule out everything in your history itself one by one, one by one, one by one. Okay. Here now you're glued to your gallbladder. Hello, yes?
Yes, ma'am.
You're glued to your gallbladder throughout, and you are dragging us, pulling us towards it. Ultimately, we all came to that only. Okay. So you'll have to discuss about others also, other causes. Only then you can come to a conclusion it is gallbladder.
ये मैडम स्टैनली मेडिकल कॉलेज के जुड़ी है
Thank you, madam.
Okay,
Thank you,
thank you,
Professor
thank you, thank
Vamsi.
you. He did it well.
And
Yes.
I think Professor Venkatrama Reddy, sir, and Professor Ajay Khanna, sir, would you like to give your closing comments, sir?
ये जो हमेशा कंडक्ट करवा
I think Venkatrama said, sir. I think sir is not here. Vamsi sir and Gayatri ma'am. I think Khanna sir, would you like to give your comments, sir?
Carcinoma gallbladder is quite a common disease in northern part of the country. We see a lot of cases of carcinoma gallbladder, and even at a very young age. We have seen the girls with 15, 20 years with a carcinoma gallbladder. And a good number of cases are quite advanced cases. Like this patient, she's just 26 years and she's been living with quite advanced case of that. And many times I think it is not that we are going to cure every case of carcinoma gallbladder. We probably will never able to cure majority of the cases of carcinoma gallbladder because their symptoms which are there, they are so vague symptoms which are there, and a good number of the cases they come to you when they are already advanced cases, and you are not able to do anything. But just for some palliation that you relieve from the jaundice, you relieve from the pain which is there. Majority like this patient, even after I'm pretty sure that giving 3 or 4 cycles of chemotherapy, still we will not able to do much for this patient. So we have to just think in terms of palliation for these type of patients.
So, Dr. Sir, do you have any doubts to be clarified? Any questions? I hope you have been preparing for the last 1 week or so. Do you have any doubts to be clarified with the national faculty here?
No, sir.
Right. So you please
No,
note down the
he doesn't
lacunar
have any
areas.
doubt at all.
So you please note down the areas where you are
Okay.
little weak. Get
Okay,
back
sir.
to the library and update yourself. And
Okay,
of
sir.
course, no, be flexible. That is what all
Okay.
the examiners have been telling. Generally, in exam, if you're going to be fixated to one diagnosis, people are going to become suspicious. Even end of the day, it can become only CA gallbladder. That is fine. But give leniency to the other similar diagnoses which are very closely related. That's what all the examiners have been telling. The
Okay, sir.
yielding towards the common causes should be there. That is a message. And then I would recommend you go to either Schlesinger or Harrison Jaundice part, not that fundamentals. That gives you more balanced presentation comfort zone for you rather than sticking onto surgical books. Maybe Schiff or Schlesinger or Harrison gives a very broader view about. They deal with both medical jaundice as well as surgical jaundice.
Okay, sir.
But the physiology, the history part, the especially when the examiner wants to test you for the liver functions and other things, medical textbooks are much better. So you spend some time reading those things as well. All right.
Okay, sir. Okay.
So also be prepared to handle the complications of gallstones in presence of gallbladder carcinoma. How to handle it? That also have to be very closely studied. You have a protocol. You please get back to NCCN guidelines of carcinoma gallbladder. It is very important document for you to work in, which every examiner will be happy to accept when you follow the NCCN guideline. So that makes things easier and right perspective, because they get updated yearly 2-3 times, and many times when you quote NCC and guidelines, the examiners will be happy to accept also.
Okay.
And for that, for you also, that becomes clarity much easier.
Okay, sir.
All right. So these are the few recommendations from our side. I wholeheartedly thank Dr. Vamsi sir and Venkatrami sir for joining us this evening. Thanks to Dr. Bharat for introducing both the senior faculty, heads of the Department of Surgical Gastroenterology. Sir, kindly permit us to invite you for GI cases. These sessions have been happening for the last 4 years, all Fridays. So thank you for joining and sharing your valuable time here, sir. Venkatrami sir, thank you, sir,
Thank
for
you.
joining this evening. I
Thank you,
should
sir.
thank Bharat sir to have introduced both of you for our sessions. So this will be available in the YouTube channel, sir. Anytime anybody wants to revisit, are welcome to do it, sir. Kanna sir,
Sure.
anything else, sir? Can we call a close?
Yeah, yeah.
Yes,
Happy
sir.
Holi to all of you.
Thank you. Thank you, sir.
Thank you.
Thank you.
Thank you, everyone. Thank you.
Good night, everyone. Good night, everyone.